Thanks for joining us for this symposium. I'm Bill Rapisi, President and CEO of the Lymphatic Education Research Network. LE&RN's mission is to fight lymphatic diseases through education, research, and advocacy. In order to win a fight, you first have to join it. So we ask, please become a supporting member of LE&RN at lymphaticnetwork.org. And we hope you enjoy today's symposium.
My name is Ionela Iacobas. I'm the medical director at Texas Children's Hospital Vascular Anomaly Center in Houston, Texas. I am originally from Romania, from Eastern Europe. I did my medical school over there, then came to New York for a neuroscience postdoctoral position, and a couple of years later started a pediatric residency at Brooklyn Hospital Center, followed by pediatric hematology oncology fellowship here at Texas Children's Hospital, Baylor College of Medicine. Then I actually moved back to New York for about 4 years. We were missing New York, I guess. But we were coming back already with a small child, had another one coming out in New York, and it's really not the same. There was no more Broadway, no more, long walks with 2 small children. So we decided that Houston is actually the best place in the world. So we came back. So since 2014, I have been back at Texas Children's Hospital, and it's been amazing. We have a vascular anomaly center here that has 24 physicians from 14 different medical and surgical specialties. It is run by a medical director, myself, and a surgical director, Dr. Tara Rosenberg from ENT. And I said we have been extremely fortunate to have an amazing team of interventional radiology, plastic surgery, general surgery, dermatology, and it's been my honor to treat patients with vascular anomalies along with my colleagues. Last year, we have received the designation of LE&RN Pediatric Comprehensive Center of Excellence in Lymphatic Disease. Since then, we have, I think, been a bit more aware of the amazing work that LE&RN has done in the field and the involvement and passion of its leaders and members. So again, it is my absolute pleasure today to present a topic that, if you want, it's close to my heart because I'm an oncologist, right, at training. So this is about vascular tumors with lymphatic elements. The topic in itself, it's a little bit outside of the usual presentations that you will hear during this series of presentations, because most of the topics will be really related to lymphatic malformation, lymphedema, different options of management, genetic background. While I'm completely outside of all of that, I'm taking you in a field where, again, the lymphatic vessels or lymphatic elements are causing a lot of problems within vascular tumors. But every single entity that I'm going to present today is rare. It's not as common as the typical lymphedema or lymphatic malformation that you will hear about most commonly within the next few months. I have no financial disclosures. So I just picked a few of the tumors, if you want, a few of the entities that we see most commonly within the Vascular Anomaly Center. But by all means, this is not meant to be a comprehensive list. It is just trying to give you a spectrum, an idea of what vascular anomalies or vascular tumors with lymphatic elements can look like. So we're going to discuss about Kaposiform hemangioendothelioma, tufted angioma, Epithelial Hemangioma, Lymphosarcoma, and multifocal Lymphangioendotheliomatosis with Thrombocytopenia. I have to give a disclaimer from the very beginning. I did not invent the names, right? So I know that they are mouthful sometimes, but these are the official diagnoses. So I think that you will see this classification again and again through different presentations, but it is because in its, if you want, simplicity and logic has completely changed what we have done in the vascular field over the last, 40 years. So since 1980, when the first classification, the first structure showed up that simply separated the vascular tumors from the vascular malformation, and decided that not everything that's pink, red, or blue is a hemangioma, a lot of advances have been in the field. And this classification, this table, has gone through multiple updates and reclassifications. And some of the entities that have been historically here, maybe about 10 years ago, have disappeared or have morphed into different names, into different entities. This is the last one that was accepted by the International Society for the Study of Vascular Anomalies in 2018. And as I mentioned, it separates the vascular anomalies in tumors and malformations. And it also keeps a list of still unclassified vascular anomalies. So vascular anomalies that will need probably a few more years of research before we are able to confirm their exact classification, to know a little bit better, that decide where do they belong. So today, as I said, we're not talking at all about the malformation. I'm going to simply take them out of this. We're just going to talk about the vascular tumors and unclassified vascular anomalies. So I will tell you a little bit about Kaposiform hemangioendothelioma, that is a locally aggressive or borderline tumor. And then about tufted angioma and epithelial hemangioma, both of them benign vascular tumors. About the Lymphangio-sarcoma, that is a malignant vascular tumor. And about MLT, again, a still unclassified vascular anomaly. And as I mentioned, all in the purpose of covering a little bit the spectrum of vascular tumors with lymphatic elements. Let me see if I can move this. Okay. So as I mentioned, we're going to start with Kaposiform hemangioendothelioma. The reason why I'm starting, if you want, in the middle of the classification, so not with the benign, not with the malignant, but with the locally aggressive vascular tumors, is because this entity, this tumor, the Kaposiform hemangioendothelioma, changed the medical therapy, changed the medical management in the field for multiple other vascular anomalies. And again, over the last decade or so, I think that most of the successes, advances that we have in the lymphatic disease field specifically are due to KHE and are due to patients that presented in life-threatening situations and needed a quick fix, if you want, or something that could save the life of these kids. So this is a patient from our center. A lot of the cases that I'm going to present today are from Texas Children's. And just to say from the very beginning, every single photo that you have here was or is part of my presentation with the approval of the patient's family. So this baby came to us at about 1 month old following a very normal pregnancy, normal full-term delivery. And he had, if you want, a little bit of a bump, a little bit of a probably bruise on the nape of the neck. And that was thought to be just due to birth, like a cephal hematoma. The area increased in size abruptly over a few days, again, at about 4 weeks of life. It changed the color to deep red or purple. And it extended to the entire neck, the right side of the face, and upper chest almost within hours. It became indurated, extremely tender, causing distortion of the ear and difficulty moving of the head and the right arm. And over the next couple of days, the platelets dropped all the way down to 2,000, where the normal would be above 150,000. The fibrinogen was very low at 46 milligram per milliliter. Again, normal would be above 220. And the D-dimer was extremely elevated, was above 20. This case was also published a few years ago in a journal with my colleagues. So just looking at this clinical picture and to the coagulopathy, we have assigned the child a clinical diagnosis of Kaposiform hemangioendothelioma and initiated medical management immediately, even without a biopsy. And I'm trying to explain why. So the Kaposiform hemangioendothelioma arises from capillary and lymphatic endothelium. And it is very infiltrative. It usually involves the skin, the subcutaneous fat, the muscles. And if you look at it under the microscope, it is marked by irregular sheets of spindle-shaped endothelial cells that will stain, will look like they have lymphatic components, the D240, LIFE1, PROX1, and also endothelial or normal, if you want, blood vessel stains. The problem with this tumor in itself, that again, it is not a malignant tumor, so we're not worried about its metastasizing to the liver or the brain. The problem is that it's causing one of the dreaded complications called Casa-Bott-Merritt phenomenon. So basically, in patients that have Casa-Bott-Merritt phenomenon, there is a increased trapping of platelets and hemostatic factors within the tumor. So if you want, the tumor in itself is very sticky. Whenever the blood will go through the tumor, it would lose the blood cells. It will lose within the tumor the platelets and some of the red blood cells, and again, together with some of the hemostatic factors. So because of that, there is low fibrinogen, high D-dimer, and very low platelet count in these patients. So if you want the official definitions that are in the textbooks, the platelet count will be below 100,000, but in the most patients that have Casa-Bott-Merritt phenomenon, it will go below 30,000. This is not a hypersplenism. It's a lot of confusion in the literature between Casa-Bott-Merritt phenomenon and other types of coagulopathy or thrombotic events that happen in vascular anomalies. So I'm not going to bore you with that. But again, every time that we discuss with our students or with our fellows, it is almost a special lecture trying to make sure that they understand the difference between them and they don't assign the diagnosis of Casa-Bott-Merritt phenomenon to other venous malformations or other, as I mentioned, coagulopathies. It is the major cause of morbidity and urgency of care in KHE, and a lot of the patients have been lost because of the Casa-Bott-Merritt phenomenon. The patients will need to be very closely monitored. They will need to stay inpatient because in rare cases or in advanced cases, they will have cardiac failure. They are extremely poor surgical candidates because of the bleeding. So you can imagine that a patient that needs frequent blood draws and has a very low platelet count, very low fibrinogen, this, again, in our case, in the pediatric world, they are almost newborns. It is very hard to collect blood from them all the time, but it is very high risk to place a central line. It is also very high risk to do a biopsy in these cases. So again, we're trying as much as possible to offer clinical diagnosis and initiate treatment soon after presentation. The problem, if you want, also is that these patients with very low platelets, by the if you want, by our training, by our hematology training, you almost by reflex, you will want to give them platelets. You want to give them some blood. You cannot just let them, bleed within the tumor under your eyes without doing anything. And the problem is that the more platelets you give them or the more blood you give them, it's practically giving fuel to the fire. So it is one of the very rare instances where we actually say do not transfuse. So unless the child is really bleeding out, do not transfuse, but consider initiating the medical therapy as soon as possible. And the medical therapy is steroids plus minus sirolimus or vincristine in some cases. And if the treatment is delayed, these patients can die because of the disease. So this is the baby that I showed you initially, again, at presentation, quite abruptly at about 1 month of age. After 3 weeks on sirolimus and steroids, you can notice the clearing of the skin. He just had a little bit of remnant around the eye and on the cheek. And then 3 months old, the entire skin is completely clean. And not only, again, clinically, but also the coagulopathy, the Casabat-Meret phenomenon responded wonderfully to the medical treatment. So we had a few values before he was admitted, but then, basically, again, he was dropping his platelet count under our eyes. And here, actually, he was bleeding and he received a platelet transfusion. So the platelets increased because of the transfusion and then dropped again into single digits within hours. We initiated the medical therapy, and in a few days, as you can see, the platelet count stabilized and then normalized and stayed normal. He came with low hemoglobin. He came quite anemic because of bleeding within the tumor, and then slowly over time he normalized and the anemia resolved. Fibrinogen, again, it's another protein that you need to form and maintain a clot that was very low initially, and then after a little bit of oscillation, stabilized and stayed normal, and the D-dimer decreased to normal levels. Just going to show you some pictures of other kids. For whatever reason, over the last few years, we had quite a few of cases of Kaposiform hemangioendothelioma that happened within the cheek. But I don't want you to believe that this is the only place where they can happen. So the KHE may happen in the head and neck, I guess, with a little bit higher incidence, but it can happen on the extremity, on the torso. It can happen retroperitoneal. Whenever it is under the level of the skin, if you want, again, retroperitoneal, the diagnosis will be slightly more delayed. And it may be at a higher risk at that point for complications and for poor outcome. So these are two patients. One came at about 8 months of age. The other one came at about 5 months. And if you can notice, again, outside of the swelling in the area, is this purplish plaque that it is in the area of the tumor. So in this case, it was very large. In this small child, I put two pictures because you cannot see it very well on the first one. But again, this purplish discoloration, that is not a bruise. This is part of the tumor, the KHE infiltrating the skin. So the first one, after 6.5 years, or 6 years after presentation, this is how he looks. So significantly decreased in size, but not completely gone. He still has a little bit of asymmetry of the cheek. There is a little discoloration, but it's more pink than purple. He's been on sirolimus, no central lines, no chemotherapy, no bleeding, no hospitalizations. But every time we're trying to take him off the sirolimus, he would relapse again, so we'd have to restart it. And this patient is about 3.5 years old right now and had only one relapse. So again, just notice the little pinkish discoloration compared to the purple one, and just mild asymmetry of the face. So that's about the KHE, and I stayed a little bit longer on it because the next entity, again, no vascular malformations, just the tumors. The next entity is tufted angioma, and for a while they were clumped together, and they thought that tufted angioma is also locally aggressive or borderline tumor, and now in 2018 it has been reclassified as a benign tumor. It was described in 1989, so again, quite recently. It has tufts of hypertrophied endothelial cell scattered throughout the skin in a cannonball distribution. It's usually just unifocal or solitary if you want, sometimes multiple. It grows slowly, and it can have the very similar indurated plaques as KG, with immunohistochemistry positive for the lymphatic markers and for endothelial markers, and rarely, but it can develop the Kassapat-Merritt phenomenon. So this is a child that presented at about 7 months of age that had this, if you want, rash, plaque on the elbow. This is his left elbow. Initially thought to be maybe a bruise, then maybe eczema, was just monitored clinically until at about 15 months old came back, and you could definitely see now coarse hair in that area that has different texture, different lengths than the rest of the arm. There was more swelling, there was tenderness, some functional limitation of the arm. So the biopsy proved tufted angioma in this case, and started on sirolimus and responding very well. Did not have Kassapat-Merritt phenomenon in this case. So another benign tumor. Again, I know we keep using the word benign here, but benign means that, again, it's not metastatic and you have a lower chance of dying from it. But by all means, it does not mean that it's something simple and easy and you can just ignore it. So epithelial hemangioma. Usually it occurs in skin and subcutaneous tissues, but it can also affect bones and liver. And it is characterized by well-defined proliferations of capillaries that are surrounding the larger central vessels. Again, I know I say this with every single one, but just to remind you, these are vascular tumors that have positive lymphatic markers. So there are lymphatic elements that are causing some of the clinical features of these tumors. The primary treatment for this tumor has been surgical excisions when you can do that. And I'm going to explain why in a minute. But if you can resect an epithelial hemangioma, then you really are trying to resect it. It is not a typical hemangioma, so it will not spontaneously involute. And in 2019, there was a study from Boston that looked at the long-term outcomes for pediatric patients, in particular with epithelial hemangioma. And they noticed that they have a higher incidence of multifocal disease when compared to adults, and they have a significantly higher recurrence rate, so 43% in children versus 8 to 24% in adults. So this child came to us when she was about 7-year-old. She had abdominal pain, vomiting, weight loss for about 6 months. And it took us another quite a few months until we were able to reach a diagnosis, confirm it, and initiate therapy. So after different imaging and different blood work, we have noticed that in the liver, she had multiple innumerable lesions of various size with very mild peripheral arterial enhancement without the typical picture that you will see in infantile hemangiomas. So we are very used to see multiple liver lesions in infantile hemangiomas in infants, but for one thing, she was a 7-year-old child at this point. And then again, by imaging, they did not show the typical picture. So we have a biopsy, and the biopsy noted that there is an epithelial vascular proliferation. So at that point, you can have either a very aggressive malignant tumor, the epithelial hemangioendothelioma, with a very poor prognosis, or epithelial hemangioma. So the malignant form has some typical genetic features, so some typical translocation and fusions, that were not found in this patient of ours. So she was finally diagnosed with multifocal liver epithelial hemangioma without any cutaneous manifestations. So when all the symptoms started, she had lost abruptly her weight, and this is how long it took basically for her diagnosis and initiation of treatment. And somewhere around my red arrow here is when we started the sirolimus. The symptoms resolved in a couple of weeks. She was not vomiting, the abdominal pain significantly improved, and then in about 9 months or so, the hepatic lesions have resolved. The MRI looked almost clean. She started to gain weight. We stopped sirolimus after 1 year and followed for her up. I think that the last time she was seen was at about 2 years after we started the treatment. She had no recurrence, continues to gain weight and do amazing. So this is epithelial hemangioma. And now we're going to something that maybe doesn't have always the same good prognosis, and this is the Lymphangiosaarcoma. Lymphangiosaarcoma was described a little bit longer time ago. So I was mentioning the other entities that were described maybe within the last 20 years or so. While we have known about Lymphangiosaarcoma since 1948 by Dr. Stewart and Travis, and initially it was actually called Stewart-Travis syndrome. So this was described in patients that had breast cancer and underwent therapy, chemotherapy, surgical resection, radiation therapy maybe, and developed that chronic large lymphedema of one arm. So years after the cancer treatment was completed, these patients would have reddish purple plaques that would develop in the area of the lymphedema. They become indurated and painful. They have chronic ulceration and they're oozing serosanguinous fluid and become painful. So most of the papers in the literature, they are specific for post-breast cancer, if you want, lymphedema that over the years develops lymphangiosaarcoma, even though the lymphedema of the lower extremities is way more common, I would say, overall. So it doesn't have to be necessarily secondary lymphedema after oncologic therapy. It can be, again, lymphedema of the lower extremities without a specific cause if you're on primary lymphedema. But there are way fewer papers in the literature describing it. This doesn't mean that it doesn't exist. Again, so we know it's out there. But if you try to put in balance how many cases of lymphedema are and how common this is at, I'm not even going to mention worldwide, but, within US, you would expect it to be way more documentation, way more reports about lymphangiosaarcoma. And again, the truth is that they are not so many. So if one would think that undergoing cancer treatment, undergoing radiation may add up some more risk factors to developing a lymphangiosaarcoma. So definitely having impaired the lymphatic drainage in an area is, if you want, the culprit, is the main problem, but may not always be the only one. So once a lymphangiosaarcoma develops, it has a very high incidence of metastasis and very poor prognosis. And the patients usually require sarcoma-type chemotherapy, but again, the survival is quite low. The histology in itself resembles angiosarcoma, so atypical blood vessels that are lined by epithelioid cells, but again, also including lymphatic markers, so being very positive for lymphatic markers. They have a very high mitotic index. That means that they proliferate very quickly. They cause necrosis, they cause hemorrhage within the tumor and externally. And as I mentioned, the treatment includes chemotherapy, but even with high core chemotherapy, with strong chemotherapy, again, the success rate is not that great. So now it comes to, if you want, to the pediatric population, because in our world, if you want, in pediatric world, we see these patients that have quite severe lymphedema quite early. So this patient that I'm showing you over here from our clinic, this is a 6-year-old child, that's a 14-year-old child, and she's a 17-year-old child. So again, one would think that if you start presenting with lymphedema from such a young age, even without an oncology diagnosis, even without having to go through radiation, there would be an increased risk of developing lymphangiosarcoma later in life if the management of lymphedema is poor, or if it's not, I guess, if we're not trying as hard as we can to improve this lymphatic drainage early on during childhood. So again, I don't want for you to believe that, we only see patients that are this late in the lymphedema phase, but just wanted to show you that you can have a 14-year-old with quite advanced stage of lymphedema, very difficult to manage even from this age. This is a picture I like to show because this is one of our patients that has very equal lymphedema in both legs, but with compression and massage, you can see the significant difference. They were working for a week, I think, just on this extremity, and you can see the difference in between them. So starting proper conservative treatment, starting proper measures very early in life is extremely important. So if you're just making a little brackets right now, this is why we are extremely happy to collaborate with LE&RN, with the network, and with the patient support groups in general, because these families, these patients, they need to belong to a family. They need to be part of a group. They need to have somebody that they can ask questions. And a lot of the times, this is not just the physicians. This is not only the doctors. They need to find resources and support, again, within the community. They need to find somebody else that's going through the same difficult time that they're having. So again, I'm really happy that we're partnering with you in this journey, and we're trying to help our patients. So only our medications, only our surgeries, or compression massage, they're not enough. So they need all of you for going forward and for helping. The other case that I wanted to show you is basically only one report in the literature that I found in the last years. There have been a few earlier, but this is another report from Boston that was published in 2012. But it is a 16-year-old girl that presented with just back pain and acute, so if you're on chronic back pain and acute chest pain and shortness of breath. And she was found to have probably what somebody would think back now, Gorham-Stout disease, or at least generalized lymphatic anomaly, but I would say Gorham-Stout disease. So at presentation, she had large lymphatic pleural effusion, diaphragmatic nodules, and she had bony destruction of thoracic vertebrae and ribs. And I included over here one of the figures from the paper, because I think that the paper in itself, even though short, is very elegant and very illustrative. So through video thoracoscopy, they have actually visualize the fluid pocket within the pleura, they were able to show the nodules on the diaphragm and again to show the pleural adhesions that will reflect on a very long or long-standing pleural effusion for this patient. So the patient had the lymphangio, had a biopsy performed, and the biopsy showed Lymphangiosarcoma. And despite multiple courses of chemotherapy with sorafenib, sirolimus, and hardcore chemotherapy, even though she had initial stabilization, the tumor recurred, progressed, and the patient was lost after 1 year. So if you want, this story is a little scary because we do have quite a significant number of patients that have Gorham's-Stout, that have chronic chylothorax, that have chronic lymphatic effusion. So at this time, I don't know which one of them has an increased risk to develop Lymphangiosaarcoma. I'm hoping none, but there is nothing that I can test for or specifically look for that will tell me that this patient is at increased risk or this patient will have, if you want, such a severe possible complication compared to the others. So again, more research is needed in the field and more involvement from everybody. So now these were the official, if you want, tumors. These are the tumors that have been already classified as locally aggressive, benign, and malignant. But as I mentioned, there are quite a few entities that are still unclassified. So one of them, it's called multifocal Lymphangio Endotheliomatosis with Thrombocytopenia. So I just wanted to show you some images, some pictures about this. And it was described again, 2004, 2005. Like I mentioned, some of these entities have been very recently characterized or have received a name very recently. And it has 2 years noted over there because under this name of MLT was described by Dr. Paula North in 2004. And the next year, 2005, completely independent by a different investigator, I think Dr. Prasad, if I remember well, it was described under the name of CAT, so cutaneous angiomatosis with thrombocytopenia. And then they realized that they were talking about the same cohort of patients. So MLT is characterized by multiple macular, that means flat or papular, so slightly raised skin lesions with this deep red brownish color. And outside of what you can see on the skin of the patient, there are multiple lesions, very similar lesions, if you want, within the gastrointestinal tract that are causing vomiting with blood or blood in the stool, so hematemesis and melena, and they are associated with low platelets. This can be present very early in life, from infancy, or it may be noted or diagnosed later, depending on the amount of bleeding that is caused by the condition. Histologically, the patients will have an enlarged thin wall. They'll have enlarged thin wall micro vessels, and again, those will be positive for endothelial markers, the CD31 and CD34. And it will be positive, very interestingly, for a specific lymphatic endothelial marker for LIFE1, but it will be negative for the regular, if you want, common other lymphatic markers that we test for D240 and PROX1. And there have been multiple therapies that have been tried, sirolimus, interferon, thalidomide, bevacizumab. But again, it also depends a lot on the age of the patient. When do you start the treatment? Because thalidomide is teratogenic. So for girls or women at childbearing age may be extremely toxic, and it can also cause peripheral neuropathy. interferon has a black box. You cannot give it below 3 years of life because it can cause spastic diplegia. Bevacizumab has another black box for cerebral bleeding. So sirolimus, if you want, is one that has the mildest side effects and has been tried in different patients. It doesn't help in everybody, but it was, I think, one of the milder ones that can be tried and has had good clinical efficacy. This is one of our patients that presented at 4 months old with intermittent vomiting blood, and he was found to have profound anemia, so hemoglobin of 4.9 gram per deciliter. And there's pictures. He had an endoscopy done right after presentation, and you can see active bleeding. That's his stomach, within the stomach. So at that point, the gastroenterologist had to do laser with argon to just stop the bleeding because it was so, again, we were not able to keep up with blood transfusions for this baby. There was no thrombocytopenia at that point. And then when we were trying to look at the rest of the body and we looked at different other areas, we noticed that the child also had pulmonary nodules that you can see over here, had bony lesions. I didn't put the image over here, and had this small purplish brown plaques. There was one on the sole of the foot, one on the back. So of course, the first thing that comes to all our minds was, this is probably a cancer that's metastatic. We'll need more treatment. So in order to better characterize it, we had to remove some of these nodules and try to find the diagnosis, try to see how to treat it. So the diagnosis came back, as I said, as MLT, and it was confirmed specifically with that LIVE-1 lymphatic marker that I mentioned before. So on a diagnosis, the nodules were quite large. Again, the child was only a few months old, so we didn't have a lot of options of treatment at that point. So we started sirolimus. And 3 months after initiation of sirolimus, you can see over here the pulmonary nodules significantly decreased. And this is just one of them that is shown in this slice, but there were multiple pulmonary nodules. The child is currently 3 years old, didn't have any more bleeds, has stayed on sirolimus since 4 months of age, did not require any more transfusions. The pulmonary nodules significantly decreased in size, but some of them are still there, so they're not completely gone. And now over the last few months, it started to scare us again because he developed new bone lesions. So we're trying to look and see what other options we have for him. But again, thankfully now he's already 3 years of age, so we're able to bridge him until a point where we can add some other agents or we can try something else. We are out of that infancy period. So as I mentioned, I was just trying to give you a few, if you want, a few elements, a few tumors, vascular tumors with lymphatic elements, just to give you a little bit of a spectrum of the lymphatic disease. So kind of trying to put it a little bit into perspective. So again, I know that we always talk about lymphatic malformations. We always talk about lymphedema, but the lymphatics can cause trouble in a lot of other segments, in a lot of other areas. And being aware of this, again, helps us study them better and helps us understand it better. So the vascular tumors with lymphatic elements specifically, they can range from benign to locally aggressive to malignant. They can be unifocal, like most of the Kaposiform hemangioendothelioma and Lymphangiossarcoma, or they can be multifocal, like the Epithelial Hemangioma or the MLT. They can affect both children and adults, but somehow they seem to have a preference. So, for example, KHE is most common in children, while Lymphangiossarcoma is very rare in children. So I think you need to have those quite a few years of really poor lymphatic drainage to have that chronic lymphedema standing there before we'll develop Lymphangiossarcoma. And then medical therapy specifically targeted at the uninhibited lymphangiogenesis appear to provide some clinical efficacy. So just giving chemotherapy doesn't seem to be that helpful, no matter how strong, no matter how damaging it is. We really need to have more precision in what we're doing. So we really need to be a little bit more targeted. And again, medical therapy that's specifically targeted at lymphangiogenesis, at the molecular pathways of lymphatic vessel formation seem to have quite a good effect. And again, we are really expecting and waiting for the next few years to have more findings in the field, more discoveries, and hopefully more options for these patients. So thank you very much for listening to me, and I would like to have a discussion now. So if you have any questions, I would be happy to answer them. I know that the presentation itself can be quite dry and sometimes quite scary. And believe me, I tried as much as I could not to put ugly photos. So let me see. There is a question about Dercum's disease, and to be extremely honest, I don't know what Dercum's disease is, but it says here that there is a large port wine capillary malformation with painful fatty lipomas that press on the nerves. So as I said, I don't know specifics about Dercum's disease, but just by the elements that you described, again, capillary malformation and lipomas that are causing pain, I would really be interested to have a biopsy and to have a genetic testing done. Because again, a lot of them, they may, even if we don't know about many patients that fit the same criteria, then if you have a target, right? So if we identify what gene is causing all this trouble, what is at the source of this, then I think that we could probably address it. And again, lipomas and capillary malformations, they are common in quite a few entities in the field. So I guess the most common one that comes to mind is Clove syndrome, but not only. So in Clove syndrome, we have congenital lipomatous overgrowth with vascular anomalies, epidermal nevus, and skeletal anomalies. But it doesn't have to be congenital, right? So some of these lipomas, they may show up during lifetime, or they may increase in size during lifetime. If you want something a little bit similar from this overgrowth perspective, would be the Peyton hamartoma tumor syndrome. So again, I would really try to see if we can get a genetic diagnosis to help with the management. There is a question about if I could mention the dose of the sirolimus. Sure. So the dose, usually the dose that we're starting with is still based on the first KHE trial. So we start with 0.8 milligram per square meter per dose, given twice a day for children that are at least above 6 months of age. But this is the starting point. And then we check the trough sirolimus level. And at that point, we are targeting, depending on the on what we're trying to treat, we're targeting different levels. So for example, in a vascular tumor like KHE, we are targeting 10 to 15 nanogram per ml. In a lymphatic malformation, maybe our target is a little bit lower. It's about 8 to 12 nanogram per ml. My colleagues in hematology that are using sirolimus, for example, for autoimmune hemolytic anemia, they are going as high as 20 to 30 nanogram per ml. So again, the target will depend a little bit on what we're trying to accomplish. Does surgery have a role in lymphedema in children? Yes, I think so. Not as and probably not as well defined as in adults. But we have children that have had cancer tumors, for example, intra-abdominal when they are 3 or 4. This has damaged their lymphatic nodules, their lymph nodes. And because of that, they have secondary lymphedema. So, you can try to do lymph node transfer in the same, if you want, same protocol like you would do for an adult that has had breast cancer and damaged the lymph nodes because of the breast cancer therapy. So again, lymph node transfer can be done in children as well. Lymphatic or venous anastomosis can be done. It's not that it's not that amazingly helpful in lymphedema. It works better in lymphatic effusions or in central conducting lymphatic anomalies, but I think that it can be tried. How does sirolimus and mTOR inhibitor specifically decrease KHE of vascular tumors? Is the effect of the sirolimus on endothelial cells, blood or lymphatics, on the platelets, on the immune cells, or the resident dermal cells? Well, I don't think that it's very, very clear exactly how it functions. But if you want one by one, it would be that sirolimus as an mTOR inhibitor, it's an anti-proliferative, it's an anti-angiogenic. So it doesn't allow new blood vessels to form as easily. So it's trying to control a little bit, if you want to calm down this crazy angiogenesis that happens, this endothelial proliferation that happens in KHE. And then if we're looking at the effect of the sirolimus, specifically on lymphatic malformation, and we see that, you use sirolimus in a lymphatic malformation that's oozing or leaking lymphatic fluid, and you have less leaks, you have less engorgement. So I think that sirolimus, it's also maturing a little bit the lymphatic endothelium, if you want. It makes it a bit more efficient. With that perspective, again, it helps a little bit to normalize some of the flow. And then in venous malformations, again, sirolimus was used with success to control a little bit the coagulopathy, to control a bit the localized intravascular coagulopathy. So there are many theories around, but the end effect is that, again, you have less clots formed, less thrombi formed within the malformation. So the endothelium is not so damaged. It's not so, if you want, sticky anymore in venous malformation. So at that point, again, sirolimus appears to have multiple effects on both blood and lymphatic endothelium. And a lot of them we still don't know. A lot of them are just, my beliefs or our theories, if you want, but they are not fully proven at the molecular level. And we're still waiting to hear from our basic scientists to give us more understanding of how this works. What can we do as therapists for these clients? Well, I think that the most important thing that you would do is actually being aware of this possibility, being aware that, in a patient that you treat for lymphedema that you may have known for years, once one of these patients will meet a physical therapist that they are comfortable with, then they're not going to let you go. They will be there and coming and looking for you year after year. So again, knowing that if you see a new wound in an area of lymphedema, that child or that adult really needs to find a physician that will take it seriously and will look for the possibility of a Lymphangio-sarcoma. So again, being yourself as therapist involved, working with the medical providers, it's really helping for the patients. Somatic mutations that have found in these diseases, well, it's not if you want, is not as clear as it is with the lymphatic malformations, or if you want, the KLA that were described. And I think that they are not the same. So one would think that, once you have, a certain cell that it's causing a problem, that it's gonna cause problems because of the same gene in different entities, but they don't seem to be the same. So, or at least I don't know about them. But the typical, for example, PIK3CA mutation that is seen very commonly in complicated lymphatic anomalies, or in lymphatic malformations, or in PROS, in PIK3CA related overgrowth syndrome, they are not that frequently described in KHE or Lymphangio-sarcoma. So, and again, a bit disappointing is that after so many years that we've known of Lymphangio-sarcoma, we still don't have a very clear genetic understanding of what is it that's pushing that lymphedema. It's taking it out of just a simple lymphedema into a malignant transformation. So there was a question about lipedema, and if there is a correlation between congenital adrenal hyperplasia and lipedema. I'm not aware of a direct correlation. Lipedema is, if you want, quite a different problem, and a very, very difficult, if you're very frustrating to work with condition, unfortunately, first of all for the patient, and for the physician as well, because we don't know that much about it, and we don't have so many things to offer, and it's really not easy to come in front of a patient and say, I know what you have. I mean, I can diagnose you clinically, you have lipedema. I can prove with a nuclear lymphoscintigraphy that this is not just a simple lymphedema. This is not obesity by all means. This is lipedema. But now that I put a label on it, now that I put a name on it, I still don't know how to treat you, or I don't have, proper agents, proper tools to help you. So by all means, a lot of supportive care are important, and referral to the patient support groups are important, but the medical management or even understanding behind the lipedema is still lags so much behind. So as I said, I'm really hoping that within the next, I keep saying, within the next few years, maybe within the next decade, we're going to have more answers, and we will be able to call back all patients that we have diagnosed now and tell them, we finally learned about it. I'm still calling some of my patients that we diagnosed with CLOVES years ago, and we couldn't do the genetic testing because of insurance restrictions. I still call them once a year and say, how is your insurance now? Can we have that? Can we help you in any way? How are you doing? So I'm really hoping that, within the next few years, we should be able to do that for patients with lipedema. So thank you very, very much for listening. I really appreciate your time. And thank you very much for the Lymphatic Education and Research Network for organizing this lecture series. And you are invited to participate the next month. Thank you.